In this session, we are going to discuss about Burkitt's lymphoma. Burkitt's lymphoma is a B-cell non-Hodgkin's lymphoma, and it's a highly aggressive tumor, and with doubling time of less than 24 hours. And it's rare in adults, which accounts for less than 1% of non-Hodgkin's lymphoma, and it's mainly in male, and typically seen in patients less than 35 years of age. And it's common in children, which accounts for 30% of non-Hodgkin's lymphoma. Burkitt's lymphoma has three major clinical presentations. The first is the endemic or African form, which presents as a jaw or facial bone tumor with swelling, and it can spread to extranodal sites including the ovaries, testes, kidney, breast, and especially the bone marrow and meninges. And the endemic forms are Epstein-Barr virus positive. The second part is the non-endemic form, which occurs in the Western, including the USA. It's an abdominal presentation with massive disease with abdominal mass, ascites, renal, testis, and ovarian involvement as well. That can also spread to the bone marrow and CNS, like the endemic one. The majority of them are Epstein-Barr virus negative. And the third form is immunodeficiency-related Burkitt's lymphoma. Usually it presents with lymphadenopathy with lymph node involvement, and it may present as an acute leukemia. For diagnosis, there is a naming which is called a starry-sky appearance on biopsy specimen. So the sky, the background, the blue background is formed by the monotonous tumor cells, which are medium-sized, round nuclei and multiple nucleoli with basophilic cytoplasm and vacuoles. This gives a sky as a blue background, and these cells are positive for B-cell antigens including CD19 and CD20 and surface immunoglobulin, and also they are positive for CD10 and BCL6, but they are negative for BCL2. And the stars are the macrophages, which are reactive, and they give a star because they are reactive and they are taking up the tumor cells which are dead, and they will have a whitish, more whitish appearance than the blue. Burkitt's lymphoma as a pathogenesis is associated with translocation involving the MYC gene, which is a proto-oncogene on chromosome 8, and it can be translocated with the 14 or the 2 or 22 chromosome, which is the on immunoglobulin heavy chain on 8%, or on the kappa on 50%, and on the lambda light chains on 5%. And this will give them as replication and multiplication of the protein, so that it will induce the cell proliferation. So this MYC gene translocation occurs in more than 95% of Burkitt's lymphoma cases. The treatment, so this tumor is extremely sensitive to chemotherapy, and the treatment should be initiated quickly because it is a very aggressive and rapidly multiplying tumor. And there are several effective intensive chemotherapy regimens, which all includes high-dose cyclophosphamide. And the prophylactic therapy to CNS is mandatory because it's a common site of relapse. And when it is appropriately and timely treated, it is 80 to 90% curable cancer. And one of the highly effective regimens, EPOCH-R, which includes rituximab, etoposide, vincristine, doxorubicin, cyclophosphamide, and prednisolone. And salvage therapy is in general ineffective, so one has to be aggressive enough to treat it when they are treating for the first time. So thank you for watching.